Jim O'Connell, a deeply compassionate physician and founder of Boston's Healthcare for the Homeless program, is referenced in a 2016 New England Journal of Medicine article titled "Liberty versus Need, Our Struggle to Care for People with Serious Mental Illness." In that article, Dr. O'Connell tells the story of a woman he encountered who lived on a stoop for 2.5 years, but wouldn't allow the outreach team to give her a sandwich or socks, screaming incessantly whenever she was approached. One day she became so unmoored and sick, the police brought her to the emergency department, and she was ultimately conserved. O'Connell ran into her years later at a meeting at a nonprofit. She was a board member, all dressed up and totally transformed. "You look fabulous," he said. And she said, "Screw you, screw you. You left me out there for all those years and didn't help me one bit." Today, Californians have a decision to make. Keep walking by or stop and stand tall in support of California's sickest. C.A.R.E represents another opportunity to stand tall. With an estimated 7,000 to 12,000 participants statewide, C.A.R.E clinical criteria provide a narrow enough group of Californians that we can absolutely meet the need and make a lasting, humane difference. I want to take a moment today, different than yesterday, to address some of the important questions I heard, the concerns raised by those who oppose C.A.R.E. First, why do this through the courts? Let's begin by the true reality of where we are today. The courts are often in the crosshairs of the lives of those suffering from severe decompensated mental illness. Often it's the criminal courts and not the civil courts, and only after we've walked by individuals screaming out from the stoop time and time again. The criminal court pathways are not an environment for anyone with impaired judgment or insight. Those disease symptoms make every new voice, every new sound, a further disorienting challenge. The C.A.R.E is a vehicle for collaboration and coordination, not just compliance. The C.A.R.E process can be protective, a supportive place that will start with a period of engagement called the settlement agreement in the legislation, allowing for the C.A.R.E participant to work with the county behavioral health program to arrange a comprehensive care plan. If over a 60-day period the care plan can be completed and on the road to implementation, the court's ongoing involvement might be smaller. In the case either because the client can't participate or the government entities can't implement an appropriate care plan that's person-centered, the court will deepen its engagement and oversight. Also, we are not asking judges to be clinicians. We ensure that the judges have clinical support to do the work that is necessary. Second issue from yesterday. What about the well-documented inequities in clinical diagnosis and the court systems we have today? These are issues we shouldn't and don't take lightly. We must acknowledge these realities and address them in the formative design of the program. We will not change these systems overnight, but we can make big improvements. We can ensure standardized tools for assessment and evaluation are reviewed by many with an eye for ameliorating these features that drive inequity. We can train individuals participating in the C.A.R.E process to ensure they have a keen awareness of these drivers of inequity and their own role in perpetuating them. We can invest in evaluation and assessment of approaches and processes in the C.A.R.E system so that we can improve them along the way. We can engage communities and stakeholders for not just in this formative days of the C.A.R.E proposal, but regularly as the program is developed for the years to come. Third, why these narrow set of diagnoses, and are we aware of the racial inequities in diagnosing and treating schizophrenia in Black and brown communities? First, the narrower set of clinical criteria is meant to follow the evidence. We know that the interventions proposed in the C.A.R.E model can work for persons suffering from these illnesses. The team treatment approach, the medications, the community-based housing. We also know this approach doesn't work for everyone, so it isn't meant to be tried for everyone. Regarding the issue of racial inequities and the diagnosis of these conditions, this is real and must be front of mind. We should challenge ourselves to improve our understanding of how these debilitating illnesses impact different groups differently, and how we can be sure our clinical processes, not just our court processes, account for these understandings and further our understanding. Fourth, why isn't the housing required? Look, the requirement for a housing plan allows the need for the individual to be more flexibly included into the overall care plan. That said, let me be clear, as the co-chair of California's Interagency Council on Homelessness, we know, the level of recent investment in housing and homelessness and additional proposed investments this year total at $14 billion, with $1.5 billion of this year's proposed governor budget dedicated to behavioral health bridge housing that is meant to target exactly the population that could be CARE Court participants. Before closing, I want to ask a question of my own. As a clinician who has led healthcare programs for the homeless in Skid Row in Los Angeles and throughout that county, who has had the privilege of overseeing jail health services both in the adult system and the children's system, who has started and supported diversion programs for those with serious mental health issues who are caught up in the justice system, I ask, why do we have to wait so long? Why must we wait until the bottom has fallen out? The charge is filed and the arrest is made. What is humane about that? Where is the civil in that approach to civil liberties? I know this is a hard issue, but maybe it's my clinical bent, my upstreamist hope, that we don't have to wait until the only system that is capable and willing to serve our sickest has bars in front and cold walls on the side, where the investments are steep and the return on those investments are quickly swallowed due to the lack of any anchor in community. I'll close by just saying, I know this is a hard issue for many of us, and these are challenging things to consider. I think today, just like yesterday, and tomorrow, as we work side by side, and a commitment from me to work with all of you, the entire administration to work with all of you, and importantly, with our partners, those who today oppose this concept, this framework, but that we can find common ground, that those channels of communication will remain open, and there's a commitment to look at every aspect of this bill to make sure we put the California way forward, a strong and committed way to the sickest of the sick on our streets. So with that, Senator Plant, I think it's Dr. Alex Kapelowitz to follow.
Okay, thank you.